Hello, everyone, and welcome back to the community table. We have been hosting conversations every month here at Beyond Type 1, focusing on a variety of crucial issues within the diabetes community and those affected by both Type 1 and Type 2. Tonight, we're talking specifically about the tech gap and issues of access, another incredibly important topic. I'm Jordan, the Director of Programs at Beyond Type 1, and I will hand it off momentarily to our awesome panelists. But first, I just want to thank all of you joining in Zoom and on Facebook Live, as well as those who make our conversations at the community table possible. Community Table is presented by the JDRF-Beyond Type 1 Alliance and made possible with support from Abbott Diabetes Care, Dexcom, Lilly Diabetes, MannKind, Medtronic, Omnipod, Roche Diabetes Care, and Tandem. While you're watching tonight, if you have questions for this awesome group, we will do our best to take some later on in the discussion, so please feel free to drop them into the chat if you're on Zoom or into the comments if you're on Facebook, and we'll do our best to get to those. For now, I'm going to ask our amazing panelists to go ahead and come on video, and I'm going to hand it off to the amazing Charisse, who's going to be moderating this conversation tonight. Charisse, feel free to take it away.
Hi, everyone. Like Jordan said, thank you so much for tuning in. I am really excited for several reasons. I'm a fan of Manny, Kaomi, and also Michelle Lichman. So I promise you this conversation is going to be amazing. So thank you all once again for joining us. And I'm going to kick it off with Manny. Also, yes. Kaomi, can you briefly tell us about your diabetes diagnosis?
Yes, as a matter of fact, well, first off, thank you for the invitation to participate in this great roundtable. I was diagnosed as a result of an annual checkup. I had the habit of going to the doctor yearly for just like check to see how things are going. And this particular time in late 2002, my fasting glucose numbers were out of range. Not way out of range, if there's such a thing, but you know, outside the normal range. I was, I remember it was like fasting 150. So my primary care physician then told me, you have diabetes. So first time I heard the word in connection with me, not in connection with my family. I had you know, relatives on my dad's side that lived with diabetes. And we did not go into what type I had. We just discussed immediate steps and therapy, which was basically one that was based on metformin and ultimately combination drugs. That diagnosis turned out to be erroneous. It had to do with the fact that I was 30 at the time and overweight, and my primary care physician, the education he had received, basically grouped people with diabetes in two buckets. If you get diagnosed as a kid, it means you have type 1. If you get diagnosed as an adult, it means you have type 2. So we went down that route. After several months, he was humble enough to admit that he was out of ideas as to what to try, because in spite of my efforts and his working with me, we were unable to bring me down to the normal range. And he referred me to an endocrinologist. And the first thing that Endo did was test me for antibodies and C-peptide levels. And I had no idea what that was for, but ultimately he said, so these are the two tests we do to verify if someone has type 1 diabetes. And I turned out to have it. So from that point on, early 2003 and onward, I have basically operated with that diagnosis and living on insulin.
Thank you. Kaomi? Oh, I think you're on mute.
All right, there we go. Thanks for having me, everyone. I'm happy to be back. My diagnosis story was a little bit traumatic. I was actually misdiagnosed. So I was having frequent urination. I was extremely thirsty. I was drinking lots of fluids to the point to where just within a 48-hour period, it went from just glasses of water to drinking almost a gallon of water. My grandmother was giving me like orange juice. My dad was going to get me Jamba juice. I did have a cold at the time. So I went to the ER and they told me that I was fine, that I was just experiencing what was probably a stomach virus, as well as having the flu. So for me to go home and to continually drink as much fluid as I possibly can. So we proceeded on with the juices and the Gatorades and everything, everything of that sort. So actually, my uncle was a type 1 diabetic. And he, listened to some of my symptoms and he asked to check my blood sugar. And at the time we thought it was displaying an error code. So we were looking at the manual, trying to figure out, what the error code was. And they figured it out and didn't tell me what it was. And then took me to the emergency room to be sure. And that's when the doctor, ran the test and said her blood sugar is 1,094. We're going to have to admit her. She has type 1 diabetes. So I was misdiagnosed with the flu, sent home twice actually from the emergency room. And then I ended up coming back to the emergency room and that's when they diagnosed me. So my story was definitely different, but I am thankful for the technology that I have now. So I'm happy to talk about this today.
Well, thank you. I have so many questions for you and Manny, but since this is not the conversation, maybe beyond type 1, and let us come back so we can all talk about misdiagnosis
Absolutely.
and how common it is in people of color.
Absolutely.
So
absolutely.
That conversation needs to happen. Also, Michelle, please introduce yourself and your connection to diabetes.
Sure, thanks for having me here. My name is Michelle Lichman. I don't have diabetes. I'm a nurse practitioner and a diabetes researcher at the University of Utah. I did diagnose my nephew a couple of years ago with type 1 diabetes. He was texting my husband different symptoms, and my husband, knowing the work that I do, he actually recognized the symptoms and said, come over, Michelle's got a glucometer. And so we were able to get him help right away. And then I have several family members with type 2 diabetes as well.
So thank you so much. So I'll start with Kaomi. You said you are thankful for the technology. What type of technology are you currently using? And then Manny, I'm gonna throw it to you. Oh, you're on mute.
Am I back on mute again? There we go. Okay, I'm really excited actually. So far, I've tried the Tandem T-Slim. X2 is what I'm using currently. And I'm using the CGM, right? I'm using the Dexcom G6, getting ready to try the new G7 when that comes out. I'm really excited about that. And they pair together, for those that don't know, the insulin pump and the CGM pair together. And they also connect to my phone, which I love, so that my blood sugar can just pop up on my phone if it's too low or too high. It's just, it's amazing. I will say it can be just as beneficial as it can also feel like a burden at times. I can't sugarcoat that. There's some positives and negatives when it comes to being on technology, but I will say it does help me with managing my blood sugars a lot better. And it actually helps me with my self-care a lot more outside of taking care of my diabetes. It gives me that freedom and peace of mind to be able to, actually spend more time just living my life, focusing on day to day, being able to just live moment to moment. So I'm really happy that I have a pump and a CGM, but there are times where I do take it off and I will still do manual injections. So yeah, that's my experience.
Nice. And Manny, I see you raising the roof, which is showing our age, because I don't know if the young people know what that means anymore. So
it's funny because like I am originally from Venezuela, and I didn't know of this expression until I came here. I saw people doing it and I thought it was like cool. It was like a celebration. Now I know what it is. But I'm on the same technology as Kiyomi. I'm also on an X2 and paired with a G6. I'll complement what she said with a couple things that really stand out for me. From the one attribute of the T-Slim X2 is that it's a hybrid closed loop. So the pump does take the data from the CGM, the continuous glucose monitor, and adjusts the basal rate, the rate at which you get little bits of insulin throughout the day to mimic your long-acting insulin. And what that does is nothing short of magical at the time that you wake up. I mean, like, I cannot say how many times I've waken up to a beautiful landing, so to speak, where my glucose levels are just precious in the morning without just by virtue of the system doing what I just described. So that's one thing I really have found super valuable to me. The other thing that I find very important of that system is the fact that with a USB connection, which you need to use also to charge it, it's rechargeable, it's not battery operated, you connect it to your computer, and when Tandem has new software, right, new functionality, for example, whenever the G7, as Kiyomi mentioned, comes out from Dexcom, they're going to release a new software for the pump. And all we're going to have to do is connect the pump to our computer and update it. And that may sound like, well, duh. I mean, like, phones do that over the air. Like, well, that's pretty unique. Like, there's no other pump in the market that does that. So that means you're not stuck with a piece of hardware until the next piece of hardware, until you upgrade to another piece of hardware.
Yeah, which that other piece of hardware can cost anywhere from, out of pocket costs anywhere from, depending on your out of pocket, could be $2,000, $3,000, $4,000, $200. So, it's expensive, especially with how fast technology is moving. To have something, I also use the Tandem as well. So to have something that you can update as soon as it is released, instead of waiting 4 years to get the next best thing, it's phenomenal. And I've also used the Omnipod and a couple of other devices as well. So let's get started with this discussion. So can you recall a time frame when you were diagnosed to when you first gained access to technology or education about technology options for people with diabetes? And if you had any barriers, what did that actually look like for you?
Yes, definitely. So when I was first diagnosed, I was 15, 16. Around that time frame, I was going to Kaiser Permanente in the Bay Area in San Jose, California. So there they had a children's diabetic side, and they also had an adult diabetics team as well. So for my diabetic team, they felt like I was not qualified for a pump because I was newly diagnosed and I wasn't managing my blood sugars well. I think back then they used to call us brittle diabetics. I don't know if that term is still being used now, but back then I was labeled as a brittle diabetic at a very young age. So instead of, educating me and my family about how, insulin pumps could help me with balancing my blood sugars a lot better, they were just kind of off the bat, just no, it's not even something to explore, not even something to talk about, not even something to think about, because I'm not a perfect candidate for one. When I was in my 20s and I started to actually dive a little bit deeper, believe it or not, I was diagnosed with it and I got enough education on how to manage it, but I wasn't really educated on it. I didn't really understand my body. I wasn't really aware of my body as much as I am now. So then I would say education was lacking for sure. Support was lacking for sure. There was just no drive or motivation to even, I guess, seek out more information about how it could help me. So when I was in my 20s, sorry to go back, when I was in my 20s is when I actually started to do a little bit more research. But I was also told that because of the insurance that I had, my insulin pump, even if I wanted to get one, it wouldn't be covered. So once again, that was just something that kind of just put it out of my mind. until I lost my insurance coverage because I fell off of my parents' insurance. And at that time, it was a year before Obamacare. So it was in 2013, I was rationing my insulin. And that's when a hospital actually, I went to a hospital emergency room because my blood sugars were too high. And I was telling them I'm having issues with accessing insulin, things that nature. So that they put me on a, kind of like an insurance plan where I would still be able to see a doctor and I would still be able to receive medications just directly through their hospital and only through their hospital, which was really awesome. So it provided me with a little bit of insulin, but still it wasn't like a routine amount of insulin until I went to a diabetes camp and to be a counselor for kids with diabetes in Washington. And it was just really interesting how I learned about just pumps and CGMs, and like there was research institutes and there was studies, clinical studies, and I didn't know any of these things. None of these things were made, available to me in the Bay Area at that time. There was no other diabetics, definitely no other minority diabetics that I saw walking around with any technology. So it wasn't cool. And there were moments where I didn't want to be attached to an insulin pump at all. So, so what that my doctors don't want me on a pump? So what that I can't get it with, insurance? I just didn't want something to remind me that I have this disease that's going to be stuck with me for the rest of my life. So it wasn't until I went to University of Washington, and they also had a program through their facility. So as long as I saw doctors through, them, they would cover the medications, they would cover the visits. And also I got that pushback from that doctor as well that, I don't think that, you've had diabetes for this long, but I still feel like, you're not ready for an insulin pump. So I didn't fight it. Then in 2016, I actually had a doctor who was willing to fight with me, the insurance company, so that I could get it. And they were asking for 6 months of blood sugars and 6 months of, your food logs. And, it was just really ridiculous, things that they were asking for. So I was unable to get on a pump through that insurance, but I switched insurances, still stayed on Medicaid. I switched insurances and I was able to get on an insulin pump finally in 2016. So it's been a very long road, and same story with the CGM, but I'm finally on technology and it's working for me. I just don't want anything to change. But if anything changes,
Wow.
I may potentially, lose my pump and my my CGM, but it's been a long road and I know I'm not the only one out there.
Well, so I have so many questions for you. And so the first one, and then maybe I'm gonna circle back, because as I'm listening to your story, right, is that if you had a healthcare provider at the time you were diagnosed, who invested in your care, right, along with you, you would not have had to wait until you went to a diabetes camp to find out that technology existed, which my assumption is probably the genetic makeup or the ethnicity of those kids at that camp were probably Caucasian. So you had to step out of your care to find that out. And it just burns me up because there's a lot of people that assume, right, that, especially people with type 2, they really don't care. And it's like, no, that's not the case. No. So to hear that over and over again, y'all, don't wait. If you're not getting the proper care, and if you have the ability to find a new provider, call the clinic's case manager, your insurance, whoever you need to call to get you switched over if it's possible, because no one should have to go through that. No, and I'm sorry you had to go through that.
No one. It shouldn't have taken, let's see, I've had it for almost 18 years now. It shouldn't have taken almost 12 years of my life, to start to understand and to be in the know and to be around others with diabetes, and to have providers and a social worker and a case manager now that are just, just amazing advocates, with me, alongside me. But you're correct. You're absolutely correct. I think it wouldn't have been as difficult if those things were more available to us in our community, especially because you're right. All the children were Caucasian. Love them all. I found that to be very, very interesting that there was just so much of it. It was just in abundance. It was information, it was supplies, it was insulin. It was just in abundance. I never seen anything like that in my life. I never even thought that even existed.
Wow. And Manny,
Wow.
after you hearing that, because I know you want to say something, so I'll
Yeah.
let you comment, and then what is your experience and access to technology? What does that look like? That journey for you?
There's two anecdotes that I wanted to share, and one of them came to mind as I was hearing Kiyomi speak. But on the technology front, and not to bash on Kaiser, but like this happened at Kaiser too. So
Oh, wow.
tell it like it is. But we had just transitioned into Kaiser. I honestly don't remember what I was on prior. And under that previous insurance, I had started on the Dexcom. At that time, it was the egg. I forget the Dexcom 7, I think it was. And I was loving it. I mean, what was not to love about being able to see your glucose levels throughout the day in response to food or exercise or stress or whatever, and learn from that and be able to adjust better. You still had work to do mentally and, adjustments, whether basal or bolusing, but it was extremely helpful. We start on Kaiser, and I mean, it doesn't occur to me that they could not cover it for someone like me. So I am I learned about the company's decision to basically take away coverage from it for it, but I will never forget the effort that the nurse practitioner in my endocrinologist's office put into fighting along with me to make sure that I did get the coverage. And just like Kiyomi's experience, like the kinds of documentation that were required to substantiate the claim were absurd. At a fundamental level, you had to demonstrate that you were you were having a whole bunch of horrendous low blood glucose episodes, and only then were you kind of afforded it, as opposed to like, okay, so this person is coming with decent control, right, into our plan. Let's continue that. Let's not break something that is working fine. Instead, there was this like disruption to try and justify what already was in place. So, reason, common sense eventually prevailed, and thanks to the hard work that the nurse practitioner put in, we were able to secure it. So that was one experience in terms of access to technology that was successful, but after a struggle. Another one, broader, if you may, in terms of access, but not just to technology, but to everything diabetes related, happened to me as I got diagnosed. So I was doing the math when Kiyomi was speaking, and I guess like we got diagnosed within months from or a year from each other. Because so in 2002, I get diagnosed. That's 2 years into being here in the U.S. And I'm honestly not all that clear as to how insurance works. And I was certainly not aware of the fact that at the time, diabetes qualified as a pre-existing condition. So if you had it and you were not covered by a large or collective policy from an employer, you were screwed pretty much. You were excluded from getting access to care. Or, I mean, I guess another option would be Medicaid. So at the time I'm working in a company with 3 employees, and my boss is considering offering health insurance as a benefit. So he gets a quote, and sure enough, when the the pool of people to be insured is so tiny. The person with diabetes just explodes the premiums. Thank you. And and when he gets a quote, he just I'm sorry, I can't do this. I can't afford this. It's so, okay, that's fine. I get it. But then innocently, I go into the company and say I will apply for a health insurance myself, right? Because I should be able to get coverage. And I get this letter back explaining how they could cover everything but things related to diabetes. It's this is stupid. That's exactly what I needed. You're telling me I can't, I don't need it for a cold. I need it for the big stuff. So if it weren't for my then wife's student insurance, so because we were together, I could have access to her coverage, however limited the student insurance may be. It was better than nothing. And it was thanks to that I could get my initial strips and all my drugs under that coverage. But so that's honestly why I struggle whenever without wanting to get political here, but whenever I hear about anyone wanting to go back to a pre-Affordable Care Act time, I struggle with that. Because even with that in place and with all the defects and issues it has, it reduced dramatically the number of people that were left out of having access to coverage. So we should be thinking how we get everyone, not how we go back to prehistoric times and make it harder for more people.
Oh, sorry, my dog. She must agree with you. Okay, so with that being said, so we also agree, that there's, okay, we can agree that there's a technology gap in the United States. We all know that. So Michelle, do you believe that disparities in tech and access are better quantified now? And can you point to any recent studies or research that's been done or seen that highlights this issue?
Yeah, thanks for the question. There have been some studies to highlight the fact that just what Kiyomi described, that people of color are not offered diabetes technology as often as white counterparts. That study has been done. It's shown to be true. I mean, and if you think about the way technology is built, technology is the majority in English. And so based on your population, we know that we have demographics that speak multiple languages here in the United States, but the technology is going to be very limited to those who speak English, and for a couple of technologies, those people who speak Spanish. And then I think that there's the fact that there's this kind of polarization of who should get technology. And there's kind of two camps. One is that anybody should get technology who would benefit. And that's pretty much anybody who wants technology would likely benefit from a technology as long as they can use it or have someone who can support them in using it. And then there's this other camp that, you only get technology if you can prove to me that you can get your A1C to a certain range. And that can be really challenging because for some individuals, the hardest part about having diabetes is checking a glucose, or the hardest part of having diabetes is to give insulin injections. And I think if you can't address the hardest part of having diabetes by offering a solution of technology that could really, really help that part, you're just creating more challenges for everybody. And so I think that the way that I like to practice to kind of overcome the technology gap is when I meet somebody for the first time with diabetes, whether you have type 1 or type 2. If you have type 2 and you're not on insulin at all, I don't mention it as much except maybe CGM. But if you come, especially if you're on insulin, we talk about CGM. We talk about insulin pumps as an option. I don't push anything on people, but you have to at least have that conversation. That should be part of the conversation, just like, what are your glucose levels? Tell me a little bit about you, and if you want to talk about carb counting or other things, but technology should just be about that base conversation that you have with anybody.
So I want to back up a bit because we know that, especially in the type 1 space, right, there's an assumption that people with type 2 don't use insulin pumps, and what I've seen, don't need them. And I'm just going to be frank, right? But that's not the case, because you just said that you talk to people with type 2 on insulin who use insulin, that you prescribe insulin pumps. Are you starting to see an intake in type 2s? I know you can only speak for yourself. In type 2s using insulin pumps, and has that access and that barrier for them gotten a little better? So just to give you a little background, back in the day, I used to sell insulin pumps. So I know the struggles that they had to go through to have a C-peptide, a qualifying C-peptide, which we know that with type 2, it's hard to have a qualifying C-peptide because it's insulin resistance there. So I'm sorry, I'm going on because I'm very passionate about this line of conversation. So I'll go ahead and let you answer that question.
No, you're absolutely right. I think that for me, the patients that I've taken care of, there's a lot of people who do express interest in insulin pumps. And I'm at a center where fortunately people can try before you buy you can try out pumps. And so we can have someone try it out to see if it's something they like. For some, it's not their jam, but for other people, they really want to pursue it. And so I think, there's interest. And one of the statistics I heard recently was from one of the R&D guys at Medtronic, that about 25% of all of their insulin pumps are for people in type 2. That's a lot if you think about how many insulin pumps are being sold. So I think that that's really important to know, that 1/4. The other thing that I think that is important is that with type 2, sometimes because of the insulin resistance that you mentioned, the demand of insulin is greater. So sometimes we need to have reservoirs that are larger. We've had to do some unique things where we have insulin pumps, but if someone doesn't want to change out their reservoir as often, sometimes we've had to supplement it with basal, sometimes off label, we've had to do concentrated insulin in insulin pumps. So I think because insulin pumps are mostly built for people with type 1 who use a certain amount of insulin, and not built for those who use more than 300 units in a few day period, we have to get creative. There is one pump that holds a larger reservoir, 480, that's the T-Flex, but for the majority don't offer a large reservoir that someone with type 2 may or may not need.
I have a question for anyone in the panel, but I suspect maybe Michelle, you have more data on this. I'm wondering, because starting someone on a pump requires, a certain, let's call it infrastructure in a practice. Like I would imagine that it's something that happens in the practice where there's an endocrinologist and diabetes educators, et cetera. And I don't have the recent figures, but my understanding is that vast majority of people with type 2 and even a significant amount of people with type 1 have as their primary care point a primary care physician. So I wonder if whether that kind of configuration, that kind of setup in terms of how we interact with a system might have also something to do with adoption levels as well.
Sure. So you're absolutely correct. So it's about 90% of all type 2 diabetes is taking care of primary care, and about 50% of type 1. So primary care is seeing the majority of everyone that has diabetes. You're right. The infrastructure might be there in some primary care practices, but probably not there in the majority. A lot of them don't even have diabetes care and education specialists that they can work with. And so it's probably more common that once a primary care provider feels like they're not sure exactly what the next step is, which kind of happened in your situation, Manny, then they get referred to endocrinology, and then maybe the pump conversation is happening. I think that there's a slight difference in the uptake of CGM. We're seeing a little bit more CGM pickup in primary care practices. Probably not enough that what we would like to see, but it's starting to pick up more and more. And so that's really good. And Teresa, I wanted to address one of the questions you asked earlier. Is it harder for someone with type 2 to get technology? It is. It's a lot harder. We have to have a lot more documentation for it. As you mentioned, sometimes labs like a C-peptide, it is harder. I rarely get rejections in type 1 anymore, but I have to battle a little bit more with type 2.
Wow. So what would you say to someone, and then I'll get back to access, because this is a huge part of the access. What would you say to someone who has diabetes and requires an insulin pump or wants an insulin pump or CGM. Because what I find is that a lot of people get discouraged and they stop fighting. What would you say to those people out there that may be listening that have been told no over and over again, no matter what type of diabetes that they have, whether it's a CGM, insulin pump, or both? What insight can you provide to that?
Yeah, so part of it is understanding the insurance. Sometimes, depending on what employer you work for, but sometimes an employer offers a couple of different insurance options. And so if you have choices, really exploring those choices to see what can be covered. I also think that, if you have to go out and purchase on your own, kind of understanding what the difference of costs might be. Unfortunately, we're in a situation where, because insulin pumps and CGM are more costly, sometimes they're just too cost prohibitive for some individuals to have without insurance, unfortunately.
Definitely, which brings me to this next question. So we know that the technology gap can be only tackled by addressing issues of access. What do you think can be done to combat these issues, knowing that the system in the US is like way complex? I think that's the only thing that's more complex than diabetes and deeply flawed. What are real steps that can be taken to see that more patients, even one, are aware that the technology exists and to be able to take advantage of those options? And that's for anybody who wants the answer.
Well, one, I feel like just because it's legal doesn't make it right. And I feel like right now it's legal for these things to continually take place, to where we are being denied access to insulin and technology. That's pretty disgusting, just generally speaking. I don't have the answers. I am one person in a community of millions of people that are dealing with this disease, suffering from it. And I feel like with there being so much out there now that can allow us to at least live a more optimal life, have a better quality of life in that aspect, I think that everyone should definitely be able to at least receive information at the very least. I do see issues with like visibility. I do also notice there's issues with certain algorithms when you go to search for different things. I'm also seeing that there are a lot more demands now, not just from people of color, but from everyone in the community, from what I see anyway online. Now, that's what I'm seeing online. What about outside of the internet? If the internet were to crash, which we all just experienced, Instagram just crashing, one of my first thoughts was, oh my gosh, there's so many people on my page that communicate with me about their diabetes or ask questions or come to me for certain things. And I go to them and I just was afraid, oh my gosh, what if I just lost all of the support that, I'm finally starting to build and develop. I feel like that same feeling of like community and family and online support needs to be also implemented in our own communities, right? From city to county to statewide. You see organizations like T1 International as well, out there fighting for the legalities and things of that nature. I think that's awesome. There's volunteers going to, speak at the Capitol and fighting, on that level. I think that's amazing. That's awesome. But I guess it's a lot easier said than done, because how can you rally? You know what I'm saying? Like we have things like the census.gov that gives us, very basic information about how many people have been diagnosed with diabetes within a certain time frame, but it's so broad and the time frame is so big that how can we create some sort of a database for, patients that come in, they get diagnosed and they get entered into a database, or I'm not sure. I don't, like I said, I don't have the answers. I just have these thoughts and these feelings, and maybe, we can come together and put our ideas together and some way, somehow make a change. But I do feel like capitalism is definitely an issue, and it's affecting our lives. It's killing people. So my heart is definitely disheartened, and I don't know what we can do, but I do believe in implementing as many solutions as possible so that we can combat this problem, because obviously it's an international problem. It's not just us here in
Wow. Can I chime in, Therese?
Oh yeah, I was waiting for you to chime in.
Well, first, like, I love the way Kiyomi opened up her comment, because I think, especially in recent years, we have gotten used to hearing or seeing, people in decision-making positions, policymakers, justify positions in light of them being legal. And so the fundamental problem is what constitutes legal or not. So I think there are some profound things that we need to reconsider as a country, as a society, that
Yes.
we're not looking at, where, at a basic level, I mean, health care, needs to be available to everyone, period. You cannot turn it, like, can there be money made in the process? Yes, that there's nothing wrong with that. But if someone cannot afford the care they need, we need to, as a society, figure out ways to help get it to those people, regardless of skin color, income, anything. We're very far from that. In fact, there's still fights to back out again, getting on my little soapbox of back out from the ACA. It's like, come on, are we really going there? I mean, like, but so I think that's one dimension definitely that needs to be addressed. Second, I think there's an element. I think there was a question somewhere in the Q&A or in the chat, or a comment about visibility and, like, I guess, normalizing to an extent. Not too long ago, there was a young woman, I think, in a fashion show, that had a very visible
Oh
Omnipod.
yeah, I
Yeah,
Kate
seen
Moss's
that.
daughter.
Kate
Kate
and I
Moss's
Moss's
thought,
daughter.
daughter. Yeah.
it's like that. I thought that was, like, it was super cool that she was, like, just very proud and nonchalant about it. Last time I remember, like, other than a celebrity that gets paid, a sponsorship fee for it, like, someone with that kind of visibility on the spotlight was Nicole Johnson back when she was Miss America, right?
Yeah.
Oh, and
So
Sierra Sanderson when she was show me your pump.
that's true.
Yes.
That's true. You're right.
Yes.
So
Mhm.
I think we need a lot more of that. Normalizing
Yeah.
it. I think we are in a better place than we were before. I think you
Absolutely.
see a lot more pumps in the wild. People showing their Libres or their Dexcoms, or, like, that's great. And normalize and, like, have conversations about it. Like, and then on the type 2 side, I think we need to be very, very mindful of the fact, and, like, here we have 3 of us in the panel with type 1, right? And we've had these conversations in the past where there can be, not only from the outside of the diabetes community, but from within the diabetes community, a lot of judgment and a lot of, like, dismissiveness towards people with type 2. And if I had type 2, that would not make me feel welcome
Yep.
as part of the conversation. So all of us with type 1 need to be very mindful of, like, what we say and how we say it in connection with people with type 2, because sometimes there are unconscious biases that are parked there that are very strong, and they come across loud and clear. And if we are in a conversation, say at a table in a restaurant, maybe in a group setting, maybe in, like, the break room at the office, like, and maybe we make a remark that might have one of those very strong biases embedded in it, you're going to basically shut up that person with type 2 who might have otherwise opened up and say, what's that thing you wear? I thought it was kind of interesting. They don't want to engage in a conversation with someone that thinks that you're, like, lazy or you did this to yourself. Like, you know, they have been judged from day one that way they were diagnosed probably. So I think there's a lot that we people with type 1, as conscious as we can be about these potential biases, like can and should do.
It's
Just
funny
some
that
ideas. Yeah.
I was gonna say it's funny that you mentioned that. So I've been in this space for a very long time, and my husband has type 2. He won't touch the diabetes online community for that reason. For that reason, he was like, I see what you do. He said, but I also see what everybody else says, and I'm not gonna subject myself to that conversation. So you got somebody who went to war several times and don't want to deal with the diabetes community because of that reason, because of the biases and the stigma and the you did it to yourself and the quick to rally around someone with type 1 who can't access something. But when you see somebody with type 2 say, my insurance just denied my CGM, and no one goes to fight for that person, that's an issue. So like you said, there are a lot of things as a community that we need to focus on as well when we think about, to me, it goes back to this. When you step in this space and you decide to speak up, it's no longer about you. It's about the people, the connections. And if you have a seat at the table, bring those stories with you, because until those stories continue to be told, it's still going to be that siloed community, or as my husband calls it, the silent majority, where people just don't want to talk because the type 1s are too loud and nobody wants to hear from people with type 2. So that's another topic beyond type 1 that we should probably have, because I want to get back to this question. So Michelle, how have you had conversations with your patients about needing access to resources, how to get technology, and can you speak to those who don't have the privilege of seeing an endo and are using a primary care, which is something that someone actually just kind of asked in the Q&A, and they're basically saying it's hard for people to learn about not just technology, but also diabetes in general when they're gate kept by their primary care physicians. This happens, of course, a lot more than people with type 2 than type 1. What are, once again, some of the issues involved in getting people with type 2 diabetes referred to CDEs, endos, information, etc.? So I gave you 2 questions, sorry.
Yeah, great question. So I think the first thing is that hopefully people have a good relationship with their primary care provider and they can ask for things and they feel comfortable to ask what they want. If they've asked for a CGM or to see a diabetes care and education specialist, and they're still, what you said, gate kept, I think it's truly time to consider, is there another primary care provider or someone else that I could be seeing? The reason why is that you guys need to, seeing a provider should be a good relationship. And sometimes you're paired based on insurance, and just like any relationship that you have with somebody, you have to be able to trust them, to be able to feel like you can disclose things, but also that you accept the advice or maybe recommendations that they're providing, or at least you can have a conversation about those things. And so it's really important to have that good relationship. So if you don't have that good relationship, exploring changing who you're seeing could be one of the solutions. One of the things that I wanted to bring up is that, you know, both Manny and Kiyomi talked about laws and how those can actually affect the cost. And I wanted to just bring up that Connecticut did pass a law that caps the cost of diabetes supplies. So we've heard a lot about the insulin capping laws, states to state, and we've done something like that here in Utah, but Connecticut has done a supply cap at $25 per 30 days supply. So if you did a CGM and you did a pump, that would be 25 times 2. But that's great, because I think that can help support some of the legislation in other states. A lot of times people don't want to be the first state. And so now that we've got one, I think that for those who do feel like they can advocate and talk to their legislators, I think they should just be aware that that exists.
Beautiful.
Wow, that's pretty awesome. So now this is going to be key. So we have about 10 minutes left. So I have a couple of questions that I want to get in. So try to keep your response just like a tweet. We're going to go old school Twitter, less than 140 characters. So Manny, Michelle, Kiyomi, We know that technology usage is up, but we know that there are still a large percentage of people living with diabetes who want to access it but cannot. What, if anything, makes you hopeful that we can actually close that gap? Remember, 140 characters or less. We will go with Manny first.
Providers like Michelle, states like Connecticut, people like all of you that are staunch advocates.
I second
Love
Manny
that.
on that. I second Manny on that for sure.
Retweet.
There is that's amazing. That was awesome. There's literally no community without unity. So it's definitely going to take a lot of us to be able to spark some change. But I'm hopeful. I'm definitely hopeful with the youth, especially seeing a lot of the youth with diabetes online, on Instagram and on Facebook. It's really awesome to see. I do believe that the youth is the truth. And if they're looking at us and they're, looking to us as, examples, and they're putting themselves out there now as examples, I think the future generation, of children that will be diagnosed, I have hope in them.
As Whitney said, I believe the children are our future. Teach them where to laugh and lead the way. Michelle, your turn. 140 characters or less.
Sure. So I think that I'm hopeful that industry is actually trying to really, really push for devices to be used in primary care. I think what that does is that it increases how many people might use it, and then hopefully that can push costs down. So I'm hopeful that primary care will improve access for everyone.
Thank you. So next question.
Shireen,
Oh, Manny, go ahead.
A reply to the most recent tweet in here. So all of us, and especially if you have voting age kids, making sure you get registered to vote and you go vote. You exercise that precious right, because it is, the last thing you can do is like complain and then not vote. I mean, like, it's no. So going to vote.
And also on top of that, just because you're not in that situation today doesn't mean you're not going to be in that situation tomorrow. Yeah. Everyone living in America pretty much is about 1 to 2 to maybe 3 paychecks away from being on the street. So think about that, keep that in mind. Okay, we're going to the next rapid fire. Michelle, who is the first person you recommend someone to talk to if they're experiencing issues with access of quality care?
So accessing quality care, probably the first thing I would think about is maybe another facility that might have a lower copay, or maybe sliding scale if that's necessary. So that, and then I also think that you can get quality information in the diabetes online community space. And so I'd recommend maybe a specific space where they could learn more.
Yummy. Where do you recommend people to talk to if they're experiencing issues with access or quality of care?
Go to your insurance. That's been my go-to. I will file a complaint really quickly. I have no problem. I advocate for myself. Sometimes there are case managers, there are social workers that can also assist you. I know in my situations, they've been a little bit more extreme, but if you ever end up in an emergency room and you're having issues with access, talk with the social workers there, talk with the case management there. They will also speak with your doctors. And I've actually had doctors on the phone in the emergency room, trying to do what they can with making calls to, helping me out. So, I mean, just ask as many questions as you can and reach out to as many people as you possibly can. Ask your fellow diabetic friends as well, too. Any questions, because I've asked questions and got information in it, and it helped me moving forward.
So I would like to throw this out there to the audience. I know talking about health is very personal, but when you think about finding out the features of a car, a cell phone, a computer, right? Don't be ashamed. The health system, as screwed up as it is, they have advocates embedded into your health insurance that's there to help you. You have to utilize that. Let's go to Manny and then And then we're going to go to the next question.
Well, you just saw when Michelle spoke, and she said that going to the online community is like that's yet another reason why we in the diabetes community love her so much. When we first started in this space, and when I say this space, I mean diabetes advocacy, like 10 years ago or so, over 10 years ago, online communities were regarded as something scary, a place where no self-respecting provider would ever refer someone to. Those days are long gone. And the reason is like, one, yes, there are courageous and supportive providers like Michelle, but we've been able to prove in communities like 2 Diabetes, for instance, since we are here hosted by Beyond Type 1, that we're good at policing ourselves. And if there's jerks, we're good about silencing them and not letting them bully other people. But far more importantly, even we're good at making sure that the information that's shared is about your experience, not in a prescriptive fashion, like saying you should do this. Like, no, this is what worked for me. So like both Michelle and Kiyomi have said, you can go to a website like 2 Diabetes and post a question about the particular issue you're encountering at any time of day or night or weekend, and get answers, get a flood of answers. Like someone once said, like white blood cells rushing to a wound. I thought that was like a very powerful image, but it's very true, where you're lost, you're clueless, you're afraid, you don't know what to do. And guess what? There's a whole bunch of people that have been in your shoes. So all you have to do is put yourself out there and post that question. And if you don't feel comfortable self-identifying yourself, you can use a pseudonym. That's fine. But get the question out there. Get some and more importantly, do not take no for an answer. Know that there's ways to get the access to the technology you need. You just have to not take no for an answer to begin with.
All right, so this is the last one, and we're going to keep this really short because we have 2 minutes left. Each of you, and I'll start with Kiyomi first. How would you advise an individual who's hesitant to use technology or advocate for themselves?
I would never advise, but I would ask as many questions as possible to gain a little bit more insight and to understand where they're coming from, and then maybe offer ideas maybe, or I can let them know what my experience is and what I've heard from the experiences of others, and maybe sharing that could potentially help them with making a decision. But I try not to, there's a lot of people that don't want it. There's a lot of people that do want the technology. So I think that's also something to kind of be mindful of too, instead of just like, get it. Like, I think it's better to ask questions to see where people are at, because it's a mentality, it's a mental shift for sure.
Yeah, and it's an individual right? Just because, there are options, people have options to say they don't want it. People have an option to say, thank you so much, I'm glad this exists. For those, it may work. For me, at this point in my life, not yet. So Manny, what about you?
Yeah.
You just hit the nail in the head. I remember when I first started on the pump, I couldn't conceive of anyone not wanting to wear a pump. Over time, I realized it is definitely a very personal decision. And quite frankly, if you are being able to, manage your diabetes and be okay and be happy with the configuration you have, good for you. More power to you. Like the simpler the better. Fewer devices, fewer things that you have to maintain that could have issues. Now, if it's hesitation out of not having information, I would really encourage people to just read online from the experience of others, what it has enabled them to accomplish, and see if that's something that resonates with you. And if it doesn't, still fine. But choosing to not be ignorant about it, but if it's working out for you, fantastic. Like there might be something else in the future, or maybe you continue doing what you're doing. If it ain't broken, no, don't fix it.
Definitely, Michelle.
I would say from a provider perspective, if I was talking to a patient, I'm lucky in that we have samples in our office for CGM. Somebody could try it for a couple of weeks. And we also have insulin pumps that we can do trials. So typically if someone's sort of interested, but kind of on the fence, usually we just do a trial and say, it's not going to hurt to try something for a short period of time. And then you can have that kind of user experience. I always feel like, because there are so many options, you should really be invested in making that decision. And especially since insurance and warranty issues, and you won't always have it you're going to have it for a long time. So usually they try it out.
Yeah, and I was going to add to that, like Manny said, yes, get the information offline. Take those questions to your healthcare provider. Call the device manufacturer and talk to their customer service. Find a CDE if you have access to one, but take those. Sometimes we're quick to say that healthcare providers don't, but you have to give them an opportunity and call them in to go through the process with you. Sometimes the assumption that they won't, call them in and try it out. But does anybody have any final thoughts before we wrap things up?
No, this was amazing. I'm just happy to be here.
It was great. And I want to point out for those who may have not noticed yet, on Michelle's wall, she has a bunch of body organs, and one of the illustrations she has is of a pancreas, which is super cool. So I wanted to call that out because it looks amazing. It tells you how amazing she is as a provider. I mean, she has this even at home.
Yeah, she's pretty amazing. I'm not gonna lie. I'm giving you some ego cookies. Michelle is amazing. So if you don't know, you should follow her, check her out, because she's doing great things for people with diabetes in digital health. For those that are deaf, she is our advocate. She doesn't live with it, but she is one of us. And Kiyomi, Michelle, are y'all good? Do you have anything else?
No, I'm all good. I'm just happy this went very well, went smooth. Thank you guys for sharing your experiences and your stories too. That was awesome.
Absolutely. Thanks for having me. And thanks to everybody who participated in the chat.
Yes, and I was going to say thank you for keeping the discussion going and keeping it very engaging. Thank you to Tiana and Jordan and Beyond Type 1 for trusting me to moderate this discussion. This has been great.
Thanks, Sharice. And I'll just close us out. Thank you to everyone tuning in tonight. Thank you to this group for sharing their experiences and expertise with us. We really appreciate you joining and talking through such complex issues. I know I learned a lot from this conversation tonight, and I know a lot of folks watching did too. And I think we all just, feel a little better too. So thank you all. For all of you watching, just want to say we have 2 more community table conversations coming at you this year from Beyond Type 1. You can register now for next month's. It's going to be a conversation around language matters. It's going to be another really, really good one, another really huge topic, and we're excited to tackle it. Be sure to stay tuned into Beyond Type 1's channels. We'll be publishing some follow-on content following this conversation and highlighting it again. So once again, just want to take the time to thank those who make this all possible. Community Table is presented by the JDRF-Beyond Type 1 Alliance and made possible by Abbott Diabetes Care, Dexcom, Lilly Diabetes, MannKind, Medtronic, Omnipod, Roche Diabetes Care, and Tandem. Thank you again to this amazing, amazing group. And thank you all for joining us tonight. We'll see you at the next community table. Good night.
Bye.
Yeah.
Bye.